Associated with the board meeting, and I'm Dr. Karen Ruban. I'm a pediatric cardiologist at the University of Virginia and have the privilege of serving as the chair of this board. So we have a quorum, and I'd like all the board members to be seated and introduce themselves as we go around. We will have others who are arriving. So if we could start with Maureen, member of the board.
Thank you. I'm Maureen Hollowell from Virginia Beach. I work for the Independent Center, which is a case management and consumer-directed service facilitation organization. And I have an adult daughter who is deaf, who has spina bifida. Thank you.
Rosie Ali, internist, consultant here in Richmond, Virginia.
And our newest member of the board, welcome. We're glad to have you.
Thank you.
My name is Peter Kongstevet, also a physician, non-practicing, but licensed in the Commonwealth. I am at George Mason University. I do private consulting and write books.
Good morning, everyone. Abrar Azamuddin, Assistant Attorney General, Counsel to the Board.
And Dr. Lee.
Good morning, Jennifer Lee, BMAS Director.
Michael Cook, healthcare lawyer, been in government in healthcare and healthcare policy out of Washington, D.C. and Alexandria, Virginia.
My name is Canon Srinivasan. I'm a non-provider member from Northern Virginia.
Patricia Cook, I'm a primary care provider in AILIT.
And if our DMAS staff and team can also introduce themselves. Ellen?
Hi, I'm Ellen Mons. I'm the Chief Economist for BMAS.
Thank you.
Policy Advisor at BMAS. Hi, I'm Karen Kamsey. I'm the Chief Deputy here at BMAS. And also, for people on the line, somebody's typing. If you could please place yourself on mute, that would be very helpful to us. Thank you.
Please place your phones on mute. Thank you.
Well, there you go.
Well then, okay. Hi, there seems to be some noise. Someone typing. Can you please mute your phone on your side? It should be muted on our side. Yeah, that's fine.
Okay. Vilma, if you could introduce yourself, please. Ms. Seymour. Yeah.
Vilma Seymour. Oops, sorry.
Just your background.
The League of United Latin American Citizens.
Thank you. And Mamie, our board secretary.
Hi, I'm Brooke Farlow.
Other team members, Cheryl. I thought I saw Cheryl Roberts. Thank you. Craig. Anyone else from the DMAS team here that I haven't recognized?
There are quite a few.
Oh, where? Oh, sorry. Okay, Brian.
Brian McCormick, Acting Deputy for Administration.
Thank you. Anyone else from DMAS here?
Actually, I have quite a few.
Okay. Introduce yourselves. Good. Thank you. Everybody? All right. Okay. All right. So again, this is a slightly different board meeting today because of the public hearing, and we are delighted to have so many of you in attendance. The structure of the board meeting will be, as I said, somewhat different because of the public hearing component, and there will be 1 hour set aside for public comments, which Joanna will be moderating for us. So again, good morning to everyone and welcome. So the first item on our agenda would be a motion for approval of the minutes from our last board meeting. Thank you. Is there a second?
Second.
Any discussion? All in favor?
Aye.
Any opposed? All right. Thank you. Next item of significant interest and relevance, frankly, is a sort of an overview of what this team did with this year's remote area medical clinic. And I would also like to recognize the late Stan Brock, who passed away this very recently and who led the remote area medical clinic for many, many years. Many of us have gone down to WISE and some of the other RAM clinics, and his work has been extraordinary. And this team has gone down as well, and as has many of the Virginia governors to the RAM clinic and administrative team members as well. So we will have a presentation by Kristen Dahlstrand, who is a health plan program analyst, to talk about the Medicaid experience down there. I think that mic doesn't sound
Testing?
There we
Okay,
go.
good morning.
Got
Good
it.
morning. My name is Kristen Dahlstrand. I'm here in the Integrated Care Division here at BMAS. And I wanted to share with you guys just about our RAM experience in this past July. We had about 20 DMAS members attend, including Michael Cook over here and Kanan Srinivasan and Dr. Lee, and people from across DMAS representing all of our divisions to go volunteer in WISE. So I wanted to share a short video, but before I do that, I wanted to give a little overview of what RAM is. So RAM is the Remote Area Medical Clinic. Over the past 33 years, RAM has provided free medical and dental and vision services to hundreds of thousands of members and recipients, and through the operation of mobile medical clinics. So every RAM clinic is free and open to the public. You don't need to have an ID. You don't need to, there are no qualifications to get in. People just show up. So they come the night before and they get in line for a ticket, and then the next morning they line up for care and they triage you to different areas. So the basic care that is offered at these clinics, if you're not already familiar, is dental care, so cleanings, fillings, extractions, which is a huge, dental is probably the biggest service area because there are so many extractions. Last year there were 4,000 extractions, and a lot of serious medical issues can be caused by infections to the gum that lead to the blood. So there's a lot of dental care that goes on. So vision as well. Some of our DMAS members learned how to make glasses while we were on site there, which was really cool. General medical, and then preventative care, so breast exams, eye exams, testing for glaucoma, diabetes screening, physicals, and then women's health. So I just wanted to share this short video with you guys just to give a recap of what our experience was like.
And how long have you been without glasses? We're gonna get your vision back today, right? Yeah. All right. I'm the muscle here. You're the muscle? Betty Jo, why are you here? All right. Why are you here today?
I'm here for the second day to get all of my teeth fixed.
Ready. Ready to help. Ready to help. Ready to help. Ready to put my head on here today.
I'm ready to get these teeth ripped out.
Ripped out?
Ripped out.
Uh-oh. Are you excited?
Oh yeah, I've been years with pain.
Yeah?
You see,
Oh, yeah.
I mean years of
Years?
all ripped out.
All right. Well, today's a good day. How did it go?
It went great. She took out 2 teeth that stayed infected, and I no longer have infection.
Woohoo! All right.
I think this is a very important thing that we're doing here. We've served 200 patients with glasses, 1 or 2 pairs, some send off, some we were able to process here in the lab. 200 Friday, 300 Saturday, and I think there's about 60 scheduled today.
How many have y'all made so far?
We made 60.
60 pairs of glasses.
I'm here to get my eyes checked for vision. I work part-time at DMV that doesn't offer benefits of any sort, so I came on down here to get my eyes checked, see if that can help with the vision that's, from reading these big computer screens all day.
You got 2 screens. You got to,
Two
yeah.
screens, and I've seen a big deterioration in my eyes over the last year.
Okay, that's about it. You can see on this slide, so we served over 1,300 people, and it provided over $400,000 in free medical care. So it was an awesome experience. Thanks for letting me share, and for everyone who helped and contributed and served. Thanks.
Thank you, Kristen. That's very, very moving. I get teary every time I see reports of RAM every year that I'd been to the RAM clinic. And I'm so hopeful that the efforts of this agency and, of course, the General Assembly in allowing us to expand Medicaid will reduce the burdens that many of these patients experience having to come to a fairgrounds and receive medical care in a barn. I mean, that's what it is, or in tents. I mean, this needs to be changed, and hopefully this exceptional expansion of Virginia Medicaid will reduce some of those challenges for the patients we serve. I might add also, many patients come from other states as well because they don't have access to care either. And I am reminded one year when then Governor Warner introduced himself to patients standing in line, and he said, "I'm Governor Warner, I'm your governor." And they said, "No, sir, you're not. We're here from Missouri and from Florida to get care." So this is a compelling national crisis, and I'm so delighted, honored, and privileged that our state has taken this great step forward. And so today's Medicaid board meeting and the public hearing will focus on expansion, and so it's a real pleasure for me to introduce our state director again, Dr. Lee, who will give us an update and comments about expansion.
Great. Thank you, Dr. Ruban, for the time on the agenda for the team to share what really was a life-changing experience for many of them. And I just want to thank Kristen, Michael, and Cannon also from the board who volunteered with us, and the entire DMAS team who went down to serve. And you'll see, I'll try to provide a brief update on some of the work we're doing to update and redefine our values. And you'll see service is one of our core values, and we live that out each and every day. It's why we're here. And I think the RAM experience was just an example of that. But thank you for the time for the team to present that.
Of course.
So just a brief update in my director's report. We have been very busy this summer and had a lot of work before us. And thankfully, we have hired some new talent to support us to do that. And I don't know if all these folks are here, but this first slide, are we on this slide? Is just listing a few of the new leaders here at DMAS. Dr. Ellen Mons here at the table, you've introduced herself earlier as our chief health economist. But we also have new division directors in the Office of Data Analytics, Mr. Jacob Wheaties. We have Jason Rachel as the new director of integrated care. We have a new deputy director of administration coming on board shortly, Rachel Pryor, who will be starting in just a few weeks. And I just want to say a very special thank you to Brian McCormick for serving as acting for these many months. Thank you for really having multiple jobs and really stepping up to in a busy time. We have Dr. Alyssa Ward, who's our behavioral health clinical director. We have a new permanent director of internal audit, Ms. Susan Smith. And I think you all know Tammy Whitlock, who is our deputy director of complex care. So lots of new leaders at DMAS, and please help me to welcome them into their roles. You know, they'll be busy and as soon as they hit the ground here. So the next slide, as I just alluded to earlier, we over the past few months have also been working to update our mission statement and redefine our core values. And we just wanted to share that with the board as well, that our updated mission statement is to improve the health and well-being of Virginians through access to high-quality healthcare coverage. And you'll note that we do see our ultimate goal as improving the health and well-being, not just stopping our mission at coverage, but really ensuring that coverage results in improvements in health and well-being. And our core values you'll see listed there as well. So service, we talked about, we're committed to serving all who are touched by our system with caring, integrity, and respect. Collaboration, we value professional, respectful cooperation to achieve a common goal. Trust, We're continuously building a culture that is honest, supportive, and fosters integrity. Adaptability. We work together to anticipate and embrace change to meet Virginia's healthcare needs. And change is just a way of life here at DMAS, as my team reminds me, so we're very good at this, adaptability. Problem solving, we promote problem-solving processes and respond to challenges with a forward-thinking approach. And I want to thank all of our leaders and all the staff at DMAS who provided input and worked to shape our new updated core values and mission statement. So next, I will jump right into an update on where we are with Medicaid expansion. Next slide. So as you heard at our last meeting, we are busy working on a number of different levels in order to implement Medicaid expansion as outlined in the budget. And these are the areas that I'll touch on very briefly and would be happy to take questions from the board. Okay. We, as you recall, have been asked to, in the budget, to work in two parallel tracks. The first track is to implement Medicaid expansion via amendments to our state plan that would change the eligibility criteria for Medicaid and open up enrollment to the 400,000, the mostly low-income adults previously ineligible for Medicaid coverage. The second track was to seek approval to develop and then seek approval for an 1115 waiver that would include both new requirements and new supports in the Medicaid program. Two parallel tracks. The budget language specifically asked us to begin working on both within 45 days of the budget being signed, and then with the second track to submit an 1115 waiver within 150 days of the budget being signed. So in a nutshell, I will say that I'm very pleased and grateful to the team that's been working, our team that's been working really hard, and that has allowed us to essentially be on schedule in both tracks at this time. So we are on schedule in both tracks in implementing Medicaid expansion and all the requirements in the budget. To go into more detail, so this slide outlines the various policies and authorities that need to be changed in order to implement expansion. There are, as you can see on the left, a number of state plan amendments and waiver modifications that need to happen for us to change the eligibility for the program. Because it is such a significant change for the program, almost every aspect of our program and our waivers need to be modified in order to adapt to that change. So in all, we submitted a total of 13 state plan amendments. And then you'll see on the right the approved state plan amendments and waivers and waiver changes that we have received back from our federal partners. Second, in that second track, as I mentioned earlier, we are also on schedule, and thank you, Dr. Rubin, for allowing us to use this board meeting as one of the first steps that we need to fulfill in our requirements for public comment and to allow for there to be dialogue around our 1115 waiver. So we have developed a draft 1115 demonstration waiver that you'll hear more about in a few minutes. And as part of the process to be able to submit that on time within the 150 days as directed in the budget, we do need to hold a 30-day public comment period. That public comment period opened last Thursday. And this meeting is one of a series of public forums in which we are seeking input and feedback on the 1115 waiver draft. All of the materials are posted on our website at DMAS. The DMAS front landing page has the waiver itself, the notice, and all the dates and times for the public hearings. And we do encourage and look forward to receiving public comments and feedback on what we have put out. We also have, I'll mention as well, that we have also begun discussions with CMS about the 1115 waiver. We've had regular calls and conversations with them about what we're required to include in the waiver, as well as where we're going with the draft. And those discussions have been very productive. Our federal partners have been responsive and helpful, and we look forward to continuing to work towards approval of that waiver from the federal government. One of the amendments that we did receive approval for, which is key for us being able to implement Medicaid expansion, are the hospital provider assessments. These are new this year and were outlined in the budget. There are 2 assessments, as I've shared previously with the board. The one that is really critical for being able to implement expansion is the coverage assessment, and we did receive approval for that from the federal government, and we needed that to be able to go forward. So that allows us to fund the state share for the costs of expansion. And as you know, the state share is approximately 10% right now. It's actually a little bit less, but does not go beyond 10% of the total cost of expansion, and that will be funded by the coverage assessment, which will begin in about 2 months, just this fall. We've shared this with you before, the delivery system. How are we planning to provide coverage for the 400,000 that we anticipate will be enrolling into care? And where we'll use our current delivery system, our 2 managed care programs, Medallion for mostly children, adults, pregnant women, and the Commonwealth Coordinated Care Plus program for age-blind disabled that provides long-term services and support. So we are working closely and collaboratively with our health plan partners and preparing for the enrollment of new adults into our current delivery system. What services are covered? We have also received approval for our alternative benefit package, which is outlined here. All the standard services one might expect in a Medicaid program: outpatient, inpatient, medications, rehab, long-term services and supports. And I'll note too, including our evidence-based addiction and treatment services. Behind the scenes, the teams are also working very hard to ensure the systems are ready for enrollment and coverage of the new population. And by teams, I mean both us here at BMAS and also DSS, our social service partners. There are incredibly complicated changes that need to take place in the information systems that form the foundation of our programs, that allow people to be screened correctly for eligibility purposes, and then enrolled into Medicaid, assigned to a health plan, and to track their use of the healthcare system once they are covered. And so the 2 systems, VA CMS on the social service eligibility and enrollment side, and the MMIS on our side, we have been working very hard with our contractors to update those systems and ensure that they are ready from a technology standpoint, a training standpoint as well for the new populations. And that has been, again, a big lift, and I want to thank our teams for continuing that work and ensuring that the systems will be ready for enrollment. And this is just a representation of, again, 2 systems, the many changes that have needed to take place in both that are ongoing. We are also engaging in testing to make sure the systems are working correctly, and they are happening concurrently. So many contracts needed to be changed, needed to be modified, systems, rules updated. It really has been a big lift on both sides in both programs. Just a note on the eligibility piece and enrollment. We have been seeking to gain greater clarity on the 400,000 who are the population that will enroll into Medicaid under the new rules, and how would we expect them to enroll in the program. And this just provides a breakdown of some of the major categories of individuals who we know and expect to be eligible, and how we will go out and enroll those who we may not know about. So just briefly, there are two populations that we do know quite a bit about, and that's because they have applied for Medicaid in the past. We just didn't have the eligibility to allow them full coverage and enrollment into services. And those are the individuals in our limited benefit programs, the GAP program, as well as Plan First. So for the GAP program, this is for those who are age 21 to 64 who have serious mental illness, otherwise uninsured, who are, of course, in desperate need of care. They do get some services through this program, but it is really not the full comprehensive set of services that they would benefit from. And second is Plan First. So these are individuals who, again, meet certain income criteria and by applying, have expressed interest in being enrolled in Medicaid, but the only program they qualified for was this limited benefit program, that very limited services solely around family planning. So these two categories of individuals who have already applied, for those we know who already meet the criteria, they will be able to be enrolled into Medicaid once the eligibility rules are changed and the systems are ready.
Jennifer, question. Do our managed... My apologies. Do our managed care partners, have they taken advantage of the IMD waiver, do we know, to be able to provide for between 21 and 64, to be able to provide inpatient services under the Medicaid managed care?
Yes.
So I think Karen would like to answer.
Yes, actually, the waiver you're referring to has to do with the ARTS program, and we sought 1115 to allow us to provide inpatient detox for those individuals in hospital settings, and they are. And we have data that can demonstrate that, and we're happy to provide that to you. So it's starting to grow in number.
Yeah, we were actually one of the first states, I believe, to seek and to get approval for this waiver. So,
but if I may clarify just one piece, that it's for substance use disorder detox. It is not psychiatric treatment for that. That is not an IMD rule that has been waived yet by CMS, although health plans can cover it. Yes, and that if you're asking about that particular part, we do have that written into our contracts that they are allowed to do that.
okay. So the second group of individuals are those we know we have some information about, but they have not applied for Medicaid in the past. And again, the largest by numbers population that we actually have enrolled in Medicaid are children. And they, of course, meet certain income criteria in their households. And so we would expect that parents of children currently enrolled in Medicaid may be eligible for our program under the new rules and might be interested in that coverage as well. So parents of children currently enrolled in Medicaid, as well as those who are currently receiving food stamps through the SNAP program, are a group of individuals who we think, again, likely to be eligible, but we need some additional information to ensure that. So we've developed an express or a streamlined application with our social service partners to be able to facilitate their enrollment into Medicaid should they be interested in having the coverage. Third is another group of individuals who are currently enrolled in the federal marketplace. These would be folks who are from 100 to 138% of the poverty limit that in terms of income, who would now be eligible for Medicaid. And we are seeking additional data and information about just who this population represents, but we do know there are some who would fall into the Medicaid new rules. The general public, so that's really everyone else who we don't have a lot of information about, but we do know that they are uninsured out there. We saw and heard earlier about the need for care as demonstrated by people lining up at the remote area medical clinic is just one example. We know that there are thousands of uninsured Virginians who are being seen in free clinics and ERs and health centers who need coverage. And with this population, we would expect to work through collaboration and partnerships to be able to reach these folks to enroll should they meet the eligibility rules. And lastly, priority populations. I'll just say briefly that we are working very closely with our community service boards to ensure that their patients, their members and clients are also enrolled into care quickly, and that they have staff trained in the systems and processes needed to get their clients enrolled into care. Just a note on a change that we are seeking to make that will help facilitate enrollment for one of those populations I mentioned, those who are currently enrolled in a qualified health plan through the marketplace. So when through this change, which would be called changing to a determination state model. So this is how our state, how Virginia relates to that federal marketplace. We can actually ask the marketplace to run the Virginia eligibility rules on those who apply for coverage through healthcare.gov. So for anybody who applies through healthcare.gov who meets Medicaid eligibility rules, they would actually run that, the exchange would run that, and then go ahead and enroll them into Virginia Medicaid according to our rules. And that would be for the population, not everybody, but for the large number of those who we believe will apply, so adults, those who are newly eligible, not the age-blind disabled group, for long-term services and supports, not that group, but the what's called the MAGI group up there, the other, whether it's children, adults, pregnant women, those who are not in the disabled category.
Question? Sorry about that. Presumably this is iterative and two-way because it can go back and forth, and people can, based on income, of course, go in and back out of an eligibility pool, and we'd like to keep it seamless. So is that how it's built?
Two-way between the exchange and
Yes, and the
Medicaid,
department in
Professor?
terms of eligibility determination. Somebody can be determined as eligible for expanded Medicaid, and then 6 months, 12 months later, fortuitously, they have an income level that takes them back out of that and back to the marketplace.
Oh, I see. So can people move if their eligibility status changes? Can they move back?
The question really is a little more technical. Is it going to be a seamless process so that
That
people
is our
don't just, they have no coverage all of a sudden?
That is our hope, that if they apply through healthcare.gov for coverage, again, that they would, if they meet the Medicaid eligibility under the new rules, that they would automatically be enrolled, if they're in one of these categories, that they would automatically be enrolled into Virginia Medicaid coverage.
Right. And that their coverage will be reviewed annually. So if at that time it's determined they no longer meet, then they could be, it will be removed unless they are eligible under another group.
Okay, yeah, my only concern is that people don't suddenly find themselves with no coverage at all. It just lapses up, they no longer have Medicaid coverage, but we don't have a good seamless way of getting them back into the marketplace for the subsidized coverage.
Okay, well,
We have existing processes in Virginia that when individuals kind of lose eligibility for Medicaid.
Keep it down.
Okay. When they lose eligibility for Medicaid, whether it is they've come in to report a change or whether this happens on their annual redetermination, we have processes to then, connect them to the marketplace to get, under a special enrollment or whatever. So those are existing processes that we currently have.
All right, next slide. Okay. And I won't read through all of this, but I just wanted to share with the board as well that given a lot of the changes that we're making in the system to streamline enrollment into the coverage under the new rules, as well as the change with the federal marketplace, we also know that we need to put safeguards into place to make sure that those who are enrolled into coverage truly are eligible for that coverage. So we currently have a very robust program integrity program, including a dedicated eligibility unit that ensures, again, accurate determinations are made and that those who are enrolled are truly eligible. But our plan is to enhance that by additional audits, testing, sampling, and a continuous quality improvement process based on what we find. And one of the initiatives we are working on and are excited to be launching next year is our fraud and abuse detection system, where we'll be leveraging our encounter processing system, encounter data, and using data analytics to look at trends and hopefully build on that to detect and prevent fraud and abuse in the system. So we're trying to leverage the best and most modern technology in order to do that. And finally, there are a lot of changes happening in the program. I've just shared a snapshot of what they are, but I wanted to make sure that the board knew where to go to get additional information in between all of our public meetings. And so just to point you back to our new BMAS website, which, as you know, we launched over the summer, it now has all of the information related to the 1115 waiver, the public hearings, as well as expansion and the link to coverva.org, which is on the next slide. We also have the ability to stay up to date with us through text alerts and email updates as we get information back. Again, it's a rapidly changing situation, and we want to make sure everybody stays updated with us. So those two things are the best, two tools are the best way to stay current. We also have launched a series of stakeholder engagement activities, including one just last week, again, where we're sharing information about the new rules, about the population that we believe will be newly eligible. And next slide, we are also launching this week a series of provider engagement town halls. So we know, again, back to our mission statement, that our mission doesn't end with just coverage. We want to make sure that the people that we serve are seeing improvements in their health and well-being, and we have to do that by ensuring that the providers are there for folks who are enrolled in coverage. And so we want to hear from providers how we can engage them in the Medicaid program, how we can make serving Medicaid patients more administratively easier and less burdensome. We have heard there are some ideas around that, but these are a series of provider engagement town halls starting this week. All of this information is also on our BMAS website.
I have a quick question. Do we work with, probably not the right term, but navigators? We have folks who would collaborate with us?
Yes, so we partner with a number of outside organizations and provide some support for navigators and actual enrollment assisters, whether they're during the marketplace, during the open enrollment for the marketplace, who can help people to navigate our program as it relates to other coverage options. And even, I just was at a meeting with some of our colleagues at DARS, and they also support navigation through our system under CCC Plus as well. So we have that for all our various programs, to support people in getting information and getting enrolled.
And they would help them fill the form and go through the paperwork?
Yes, they help. Yes, there are people who will. So we have there are a number of places to get support. So there are there will be enrollment assisters out on the ground, actually helping people through the process of applying. We have the Cover Virginia call center and central processing unit. So anyone, even now, can call if they want information about the upcoming changes. But On the phone, they will be able to walk you through an application, applying for the program, and we'll be able to process an application. And then, of course, all of the local social service agencies and our partners at DSS, at Department of Social Services, are out there in localities working to help people enroll.
So, to follow up on that, does that include trained, certified professional interpreters on the ground? I understand call centers, and I understand when you're in other places, but if we're doing outreach, or outreach is being done in the community, workshops, whatnot, are there trained interpreters as opposed to someone who is of the same family, language family?
That's a great question, and I think it's something we need to look into. We do want to make sure there's good language access and communication in all the communities across Virginia. So I think that's something that we can get more information about and get back to you on. It's a great question.
Just a quick comment and then a question. Just a comment for those of us who lived through the transition to the Affordable Care Act. Just please, whatever we do, make sure we have enough phone lines open and enough people to answer them as it starts out. I'm sure you've thought of that long ahead of me. Will we be able to attend, and will the board members be allowed to attend these any of these provider meetings?
Absolutely. We would encourage any board member to join us for these provider meetings. We would be delighted to have you there. And just to wrap up, so I believe the board has seen these before. These are mock dashboards. Again, not real information, of course, but just what as we're planning ahead for these major changes in the program, we do want to be able to report back as quickly and as accurately as we can on what's happening in the program. So who are the people enrolling? What is their, what are their demographics? Where are they from? What do we know about their health status? And how are they utilizing services in the program? And then secondly, too, what has been the impact on the budget? So as you already know, the expansion actually leads to savings in the budget because the state had been investing funds to support folks getting care. Even now, it's just that they're not getting the best care in the most appropriate place, the preventive, continuous care that they need to stay out of the ER and to stay healthy. And so, but we do want to be able to report back as soon as we can. There will be a lag in time here, of course, as we get the data, but on the impacts to the budget and the program. So that's one of our goals. And next slide. Oh, that's it. Okay. Well, and essentially, if you need more information, coverva.org is the best place to go. But I'll just conclude that with that as the update on where we are with expansion. And if it's okay with you, Dr. Ruban, I can turn it over to
Absolutely.
Dr. Ellen Mons. So as I mentioned,
Compass, right?
yes. So
Quickly, I have a quick question. On the 1115 and the state amendment plans with CMS, what is their time frame to approve? Do they have a mandated time frame?
on the state plan amendments, CMS does have a mandated time frame. On the 1115 waiver, they do not have a mandated time frame. So our best indicator is really to look at the experience of other states as they've sought approval for similar 1115.
And then we need both to move forward, right? No.
Right. We're seeking, as outlined in the budget, we can go ahead and change the eligibility rules once we have this.
January 1st, right?
Yes, once we have approval from CMS to begin coverage on January 1st. In fact, it says no later than January 1st of 2019. And the second track, we are working to submit, and this is part of the process, to submit the 1115 waiver by the 150-day deadline.
Thank you.
And yes.
Thank you, Ellen.
Great. First of all, I apologize for my back being to most of the folks here, but control my own slides this way. So good morning, everyone. As introduced, my name is Ellen Mons. I am the Chief Economist and Director of Economic Policy here at BMAS, and I'm here to present an overview of our 1115 waiver extension application that is out for public comment currently. We're calling this the Virginia Compass demonstration. So an agenda for the talk here, and I will roll on here. So just want to make a note that the slides I present here today, as well as the full public notice and the full application, waiver extension application, are available on the DMAS website. Just if you go to dmas.virginia.gov, you'll be able to click from there. Also, there's a more detailed address included in the presentation. So under Section 1115 of the Federal Social Security Act, the federal government has authority to approve a state's request to waive compliance with provisions of federal Medicaid law. An 1115 waiver must be experimental, likely to assist in promoting the objectives of the Medicaid program, budget neutral to the federal government, and limited in duration. And importantly, states must provide a public process for notice and comment on proposed demonstration applications and extensions, and as noted before, we are in our 30-day state public comment period. Broadly, our 1115 waiver extension application has kind of two broad components. The first is an extension of our existing programs in our 1115 waiver that Virginia currently has that are set to expire at the end of 2019. These include certain components of our arts benefits program, which we discussed earlier in the IMD exclusion, and our coverage of former foster care youths who aged out of coverage in other states. Second, our waiver extension application proposes new programs as called for under the 2018 Appropriations Act. On June 7th, Governor Northam signed into law the 2018 Appropriations Act, which did as we've just recently talked about, two things. First, we authorized DMAS to expand Medicaid to adults 19 to 64 with incomes up to 138% of the federal poverty level, effective January 1, 2019. Additionally, on a separate track, the Appropriations Act directed DMAS to submit a waiver within 150 days, asking for federal approval to add new features to the Virginia Medicaid program with the goal of that they are designed to empower individuals to improve their health and well-being and gain employer-sponsored coverage or other commercial health insurance coverage. Next, we'll go over the specifics of the new changes and the new programs proposed in the 1115 waiver. The 2018 Appropriations Act set forth new rules for different sets of Medicaid populations, which we have bucketed into kind of three programs, which I'll next present. The first of these programs is the Training, Education, Employment Opportunity Program, for shorthand called the TEOP, which is a program to promote work and community engagement in Medicaid. Largely, this program conditions Medicaid coverage for adults with income up to 138% of the federal poverty level on compliance with work and community engagement, with certain enumerated exemptions that I'll go over to improve Medicaid enrollees' health and well-being and financial stability. Some people, as I mentioned, will be exempt from the work and community engagement requirements of the TEOP program. Broadly, there are two types of exemptions. One are a standard exemption. These include, for example, primary caregivers of dependent children under age 19, those who are medically frail, individuals with disabilities, and those who are currently enrolled in SNAP and TANF. Another exemption will be hardship good cause exemptions. For example, a hospitalization, a death in the family, or a natural disaster.
Will we have the opportunity to ask about those things later, or?
I think at the conclusion of Ellen's.
Okay.
Sure.
Thank you. So adults who are not exempt must participate in one or more qualifying activity, whether it be work or community engagements, for increasing hours of requirement starting at 20 hours per month and eventually escalating to 80 hours per month. Importantly, individuals can engage in one or more of many activities to meet these requirements, including things like employment, skills training, education, caregiving services, and many others as enumerated in this application and will be enumerated more going forward. As set forth in the Appropriations Act, if an enrollee does not have an exemption and they fail to comply with their work and community engagement requirements for any 3 months within a 12-month period, their Medicaid coverage will be suspended. Importantly, members whose coverage is suspended can have their coverage reinstated if they comply with work and community engagement requirements for 1 month, so they show they are back in compliance. 2, they qualify for another Medicaid eligibility category that is not subject to the TIAP or an exemption, or they turn age 65. DMAS and its partners at DSS and Workforce know that Virginia members value work, but we recognize that Virginia's Medicaid population faces unique employment, poverty, and other important circumstances that interact with an individual's health and well-being and their ability to engage in TIAP work requirements. Therefore, we propose a multi-pronged, comprehensive approach to meaningfully connect TIAP participants to the supports necessary to be successful in meeting the new program requirements. For individuals who have not been identified as exempt or already meeting qualifying activities, the Commonwealth will provide information regarding TIAP requirements, including that the individual must participate in an assessment to assist with meeting the requirements. The assessment will include a process to identify enrollees who need employment supports and connect them to their needed services. So on this slide, we'll have an enumeration of what we're thinking of in terms of how we provide employment supports for individuals in the TIAP program. So we're going to do this in 2 ways. First, we will seek administrative efficiencies in our current workforce programs in Virginia. And second, we will be seeking additional federal matching dollars for employment supports specific to individuals in our TIAP program. The second program called for under the 2018 Appropriations Bill is one that we refer to as the Health and Wellness Program. Under this program, we will implement premiums, healthy behavior incentives, co-payments for non-emergency use of the emergency department, and health and wellness accounts. This program will apply to Medicaid expansion adult enrollees who are between 100 and 138% of the federal poverty level. Individuals with income 100 to 125% of the federal poverty level will be required to pay a premium of $5 a month. That number is $10 for those between 126 and 138% of the federal poverty level. The same categories of individuals that qualify for the TIAP exemptions will also be exempt from the Health and Wellness Program. Virginia will make coverage for these individuals effective on the first day of the month after an enrollee pays his or her premiums. And third parties, like employers or churches, may pay premiums on an enrollee's behalf. And also as noted in the 2018 Appropriations Act, if an enrollee fails to pay his or her premiums for a time, which we have selected as 3 months, their Medicaid coverage will be suspended. However, enrollees can re-enroll in their Medicaid coverage after making their premiums, after making new payments of their premiums, or, as noted previously, qualifying for an exemption. Premium payments will go into the health and wellness accounts. People who make the required number of premium payments and do at least one healthy behavior, for example, a kind of primary care, doctor's visit, flu shots, pap smear, et cetera, and will be able to receive a Health Rewards gift card to pay for health-related services, for example, eyeglasses or vitamins. People who make the required number of premium payments but do not do a healthy behavior will not get the health reward back, but their health and wellness account money will roll over to the next year, and they will have another chance to earn the healthy rewards. Importantly, finally, we have a third component of our 1115 waiver extension application, and that is housing and employment supports for our high-need population. The Commonwealth will provide certain eligible high-need Medicaid enrollees the support necessary to obtain and maintain employment and stable housing, seeking to improve members' quality of life and health outcomes. The individuals who we're seeking to help in this program are those that will be exempt from any of our TOP requirements or any of the premium requirements. These are individuals that will meet a needs-based criteria. So they will have either a behavioral health need or a serious and complex medical condition. And additionally, these individuals will have specific risk factors that will allow us to provide the housing and employment supports necessary to lead them to success. On this slide is just kind of a brief examples of what sort of housing supports may be provided to this population under this program. And on the following slide, we have a list of employment supports, examples of employment supports that we'll provide to our high-need population under this program, including case management, educational services, pre-employment services, and employment-sustaining services. Very quickly, like in all 1115 waivers, we are required to do an 1115 evaluation. So 1115 waivers must test and evaluate the goals of the waiver's components. And upon approval of the Virginia Compass waiver by the federal government, our state will work with CMS, the federal government, to provide an evaluation design and get approval for that design. Some of the hypotheses which this waiver will test, which we've included in the application, include members enrolled in the demonstration will secure sustained employment. Another one is participating in work and community engagement requirements will improve member health and well-being. Finally, before we open up the floor for public comment, I do want to note that there are many ways under which the public can provide comment for this waiver: by phone, by email, by regular mail, and in person. All of these ways are outlined in our slides. And that in addition to this current public hearing, we have 3 others in Roanoke, Great Falls, and Virginia that will follow in the next few weeks. Thank you.
Thank you very much. I'd like to ask board members if they'd like to have any questions answered by Ellen before we proceed to the open public comment period. Dr. Ali.
Quick question, Dr. Mons. What percentage of the 400,000 for Medicaid expansion do you think qualify for the TOP?
Yeah, so we've included some of these estimates in our application, and here we've relied on JLARC's estimates that they provided in the budget process. And so they estimated that roughly 120,000 individuals will not be exempt from the TOP requirement, and that of these 120,000, they estimate that roughly half of those individuals will either already be working more than 20 hours per week or enrolled in education, so kind of narrowing the focus to around 60,000 individuals.
So
Peter.
my questions may be a little bit in the weeds, so I'll defer them for the moment.
Mine is more of a suggestion on the premium payment. If somebody doesn't pay 3 months premium, would they get a option to do an auto pay? Because I've read studies of other states which had the premium payment, and my suggestion would be to kind of study their practices, best practices, their learnings, to make sure, because I think this is one of those areas where, I can't remember the name of the state, where they found folks falling off because they just didn't realize that they were behind on payment. Thank you.
Thank you for that suggestion. We will certainly kind of, and have been reaching out to other states. And as mentioned in the waiver, we do say, we are uniquely concerned about the unbanked population. And so we will do outreach with other states and kind of our goal is to put in place,
There could be other innovative ways.
That's right. We are open.
Thank you.
Just a quick question about our correctional population that will be covered. Are they impacted by the waiver per se or a special consideration?
Right, so one of the exemptions enumerated in the TOP exemptions is for individuals who have re-entered, and for the next, and I forget this, it's either 6 or 12 months that the exemption, because we recognize the unique needs there.
Thank you.
Yeah.
Good morning. Can you clarify? Can you clarify what will happen to the individuals who are already currently enrolled in the marketplace?
Sure. So for Medicaid expansion?
Yes, ma'am.
Sure. So as Dr. Lee mentioned earlier, we have individuals who are currently enrolled in the marketplace who are potentially newly eligible for Medicaid expansion. When individuals come in during the normally scheduled marketplace open enrollment period, they will get a redetermination of their eligibility. Now, if this, if they receive this redetermination and they are kind of newly eligible for Medicaid expansion coverage, they will get notice of that. That'll be transferred. That determination will be transferred to Virginia, and then we will, kind of follow on with the, enrollment cards, and here's how you select your plan, et cetera. So, our goal is to make it as seamless as possible.
Peter?
Just a question on following up with folks on the work requirement to make sure that people do not fall through the cracks who just fail to register. We've seen Arkansas and what's happening there, which is kind of a travesty. Have we started talking to various groups to figure out mechanisms to avoid that? Things like apps, maybe getting our insurers involved if there's a way to have something pop up when somebody hits 2 months.
Yes, and we have been closely following what is going on in other states, and we will, we are seeking to learn from other states. What the way that we kind of implement the work requirements, we're currently fleshing those out. We will do that in negotiations with CMS, but also with our partners here in Virginia and nationally to learn from best practices there. But we are tracking.
If we've got some thoughts, on that, is there anybody we can talk to provide ideas, which I'm sure you guys will all come up with, but just in case we have a stroke of brilliance while we're sleeping some evening?
You may email me.
Fair enough.
Peter?
Thank you.
Thank you. And follow-up to that, really, it's one of those deep dive, but maybe I can cover it just by asking a simpler, higher-level question. We now have at least a number of published studies that have come out that are in the health policy and medical literature, which I'm sure you've read and are fully aware of. Are we looking to identify ways to ameliorate the issues that have been addressed? Because there's that, Michael pointed out one, but there are some others too.
Yes, we are following closely the experience in other states, and I know, that CMS, that our federal partners are as well. And so when we are, I can't read tea leaves here, but in particular, this is all a negotiation. This is a waiver application. And, we will go through kind of a very deliberative process that begins with this public comment period and moving from, the what to the how. And I think a lot of what is involved here is in the how. And thank you for that comment.
Vilma, you have a question?
Thank you. Please help me understand the enrollees, the income. Is the annual income range has listed here, the highest one to 16,000. That's the highest for people to be able to be eligible to enroll?
So for an individual.
That's what I'm saying. So with the living wage being, so many people not making that living wage and working full-time but without benefits. So if one individual makes $26,000 a year, they're not eligible for this?
For Medicaid?
For Medicaid.
Right, the federal poverty level for the new Medicaid expansion level goes up to 128, or 138% of the federal poverty level. So for a person of one, that is indicated here at the income cutoff limits, yes.
Yeah, but they would be able to get, they would be able to go on the exchanges and get subsidies, federal subsidies, which really ameliorate a substantial amount of those dollars.
Thank you.
Ellen, one more, just a quick comment. Years ago, I was a dumb young kid lawyer on a List Crick grant sitting in a storefront law office when I was in law school. And I remember being hitchhiking down the street, being picked up by my clients who were in the Pennsylvania Welfare Rights Organization. They'd been sitting in at the work incentive, what was then the work incentive offices. Not only didn't they have jobs for them, they didn't have job applications. I presume we've moved past that, and I presume I'm really excited about your employment part. Just make sure there's some coordination there so that we get dollars, but nobody is able to do anything with them.
And for this very reason, we are greatly appreciative of our partnership with our sister agencies at the Department of Social Services and our workforce colleagues. So thank you.
This agency can't do everything, right?
We cannot.
That's right. Okay, I think it's time to move on to the public comment period then. Some official language to read. So we'll move on to public comment period of today's meeting. Those who indicated they would like to give public comment today at registration will be called to the podium in chronologic order and will have 2 minutes to speak. We will end the public comment period at 12 noon. The goal is to share information publicly about the contents of the waiver proposal and gather questions and comments about the concept. This process is required by federal authorities and serves as an opportunity to improve public understanding about the new opportunities and requirements. It's important to establish expectations at the beginning of each hearing, so please understand the process. We want everyone to have time to ask questions and share your comments about the proposal. We ask each of you to respect the 2-minute time requirement. You may file written comments to supplement your remarks today and other ways of providing comments, as Ellen has shared. We are listening, we hear you, and we are documenting your comments, and we will be responding in writing to every question. Our answers will be available to everyone here today, as well as to others who could not attend, so it is important we follow this process so everyone has accurate, consistent information about the proposal. You are all important components of this process, and in particular reviewing the waiver proposal, and we are committed to make sure everyone's voice is heard. So Joanna, thank you for moderating this process for us, and thank you all who have signed up to submit comments as well.
Okay, so just want to check that this is on. Can everyone hear me? Okay. So thank you, Dr. Ruban. And briefly, I just wanted to clarify that to your question, a standard exemption is individuals who are incarcerated within the past 12 months. So that is part of our waiver, and it's also on the website. You can view all of our exemptions there. So again, my name is Joanna Fowler, and I'm a policy advisor here at BMAS. And I will be calling folks to the podium today in the order that they registered to give public comment for 2 minutes, and we're going to have a timer up here. So I just want to echo Dr. Ruban's comments that we very much appreciate you all being today to give public comment, and we are very much in listening mode, recording and transcribing all of your comments so that we can respond in writing. So let's go ahead and get started. First up, we have Rhonda Thyssen from NAMI, Virginia. Thanks, Brenda.
Thank you. Thank you, Madam Chairman, members of the board. My last name starts with T, so I almost never go first for anything, so I appreciate it. I am Rhonda Thisson, Executive Director of the National Alliance on Mental Illness of Virginia. NAMI Virginia has some serious concerns about the waiver application. We do thank you for including housing support services and support employment in this application, which are very important services for our constituency. We're especially concerned about the work requirement, and especially because we learned from Dr. Lee, thank you, at a recent meeting that in some of the other expansion states, the expansion population had an incidence of 30% of mental illness, which is higher than in the general population. We support work as a means of sustainable recovery and as a means, obviously, of self-support. This is especially important because in the population that are participating in community mental health services, only about 1 in 5 are employed, and only about 1 in 20 people with schizophrenia are employed. So it's very important that people obtain and maintain secure employment. So to that point, the work requirements demonstrated in research really don't advance the cause of getting people sustainable work. I mean, studies demonstrate that there are limited short-term benefits to work requirements and no really substantial increase in income over time. And given the challenges to folks, especially those that are dealing with mental illness and basically complying with difficult administrative requirements, we're extremely concerned about people losing their coverage. I mean, there are some populations that could be hurt by these requirements that aren't covered by the waivers. For example, young people that are experiencing their first symptoms of serious mental illness, such as those that are experiencing their first episode of psychosis. It's very important for that population to get consistent, effective treatment because early intervention is key for those folks. We're really worried that a population like that would lose their coverage because of the complexities.
Whoa. Oh, my God. Okay.
No problem. Is that the hook for me? Is that?
So Rhonda, that's your cue to end your comment.
Oh, so that was 2 minutes? Was that 2 minutes? Oh, well, okay.
Yes.
So just one more thing. I just want to say, despite this significant evidence that low-income folks obtain and maintain low-wage employment that barely feeds their families, these requirements are based on the assumption that people will only go to work if they're forced to go to work. And I think we all know that that's not the case. And so we really urge you to remove the barriers to health care and not expand them. So thank you for your time.
Thank you very much, Rhonda. We really appreciate your comments. And I apologize about the alarm. I wish my alarm at home went off like that so I'd wake up in the morning.
So thank you for your comment. Sorry, we just want to pause a second and make sure that alarm is turned off. Is that turned off? Yeah.
I'm sorry. Everybody awake?
I hope that wasn't being transmitted to the video. I probably didn't.
Sorry for that. We didn't. Yeah.
Okay. So we'll continue, and I can just time it on my phone. So next we have David DiBiase from AARP Virginia. And I apologize if I mispronounced your last name.
You did fine. I'm still in shock from the startle. Members of the board, my name is David DiBiase. I'm an Associate State Director at AARP. Thank you for this opportunity to comment on the proposed waiver. Like other stakeholders, we have not had sufficient time to look at the proposal, but to consider it in full. But we want to have a few comments here. We strongly support Medicaid expansion, but we have concerns about specific aspects of this proposal. Imposing work requirements would make it unnecessarily hard for many Virginians who need health care the most to get it. This includes many people who deal with bouts of illness due to chronic and behavioral health conditions. AARP is concerned that people who have a hard time finding work will lose coverage. Research indicates that Americans over the age of 55 spend longer trying to get employment and then have longer periods of unemployment compared to their younger counterparts. AARP is concerned that these individuals will lose their coverage, leaving them more vulnerable to getting sick and developing long-term health problems. In addition, there is research that shows a strong association between being unemployed and poor health outcomes, which makes coverage during unemployment even more crucial. AARP is also concerned that some Virginians will likely experience difficulty in applying for the exemptions, which could cause many people to lose their coverage. For example, studies of TANF have found that beneficiaries with disabilities and poor health are more likely to lose benefits due to difficulties navigating the system. For these reasons and more, AARP believes the proposed waiver will make it harder for Virginians to get and stay healthy, and this runs counter to the Medicaid Act. For additional details on our concerns, we refer the department to our written comments that will be submitted later during the 30-day period. Thank you.
Thank you, David.
No warning.
That was perfect. That was right at 2 minutes. And also, just want to echo David's statement at the end that please submit your comments also online and all of the ways that Dr. Montz outlined that we have to submit them. So next up, we have Dora Muhammad from the Virginia Interfaith Center for Public Policy.
Good morning, Dr. Lee, boards, members of the board. Thank you for holding this public hearing. As a committed advocate on behalf of the vulnerable and poor in our communities, the Virginia Interfaith Center for Public Policy, I feel like you all can't see me because I'm so short, strongly opposes the work requirements and monthly premiums incorporated in the 1115 waiver. Our position is rooted in the belief held by diverse faith communities that quality health care is essential for people to attain and sustain the fullness of their human dignity. After diligently working to make quality health care affordable to hardworking, low-income individuals and families in the Commonwealth, we cannot now attach regulations that will hinder, block, or potentially revoke access to that care. The waiver explicitly notes that an estimated 26,000 Virginians will lose their current Medicaid coverage if these regulations are imposed. These regulations will place unnecessary burdens on the poor as they try to navigate the complex and costly bureaucratic system that this state will be compelled to create in order to manage the new processes of these regulations. Medicaid was created as a program to help, not hurt the poor. The 1115 waiver, therefore, should only contain provisions that are proven to facilitate an increase in care. The current provisions for work requirements, monthly premiums, and the health and wellness accounts do not and should be removed in order to ensure the most effective and humane implementation of Medicaid expansion. Thank you.
Thank you, Dora, for your comments. All right, next up, we have Jill Hankin from the Virginia Poverty Law Center.
Good morning, Madam Chair and members of the board. I'm Jill Hankin from the Virginia Poverty Law Center. Thank you for this opportunity today. As was mentioned just a moment ago, the purpose of an 1115 waiver is to allow states to experiment with initiatives and policies to promote the purposes and objectives of the Medicaid Act. And Virginia has a long history of doing that with its 1115 waivers. For example, our nationally renowned arts program is an 1115 waiver, so is GAP. So Virginia has taken steps through 1115 to expand programming, expand access to care in harmony with the Medicaid law. However, this waiver does not promote the purposes of the Medicaid Act. Specifically, the provisions related to the work requirements and the monthly premiums fail to meet basic 1115 waiver requirements. And I'll list 3 reasons for that. Number one, as I read the proposal and look at the numbers and crunch the numbers, it looks like 21,000 people are expected to lose their coverage because they will not be able to meet the work requirements. They won't be exempt, and they'll be losing their coverage. And another 6,000 individuals are expected to lose their coverage as a result of failing to meet the monthly premium requirements. So we're talking about 27,000 people losing their coverage. That does not promote the purposes of the Medicaid Act. Secondly, there's a big cost to this. As Dr. Montz described these provisions, it's pretty complicated. And detailed administratively. There's a lot of red tape. There's new bureaucracy. It's going to cost we believe, over $25 million to implement these provisions. That's what was discussed at the General Assembly. So there's a great deal of cost, and we believe those dollars could be better used elsewhere. And just thirdly, again, about the complexity of this system, people will fall out of coverage because of their inability to meet the new requirements. The health and wellness account, while probably well-intentioned, it sounds ridiculous to me. Putting a $5 and $10 premium into an account, having to get a basic health service, then
Jill, I'm sorry, we're
yeah.
at 2 minutes.
Well, these are the concerns that we have, the loss of coverage, the cost, and the complexity. So I appreciate the opportunity to make these comments today, and I'll follow up with more details.
Thank you so much. We really appreciate it. Okay, next on the list, we have Rebecca Bowers-Lanier from B2L Consulting.
Good morning, Madam Chair, members of the committee. Can you hear me okay?
We can.
Oh, okay. I do have copies, but I represent six clients today, so I figure I have 12 minutes. Not. We are all members of the Healthcare for All Virginians Coalition, and they are the Brain Injury Association of Virginia, the Hemophilia Association of the Capital Area, and the Virginia Hemophilia Foundation. The Substance Abuse and Addiction Recovery Alliance, also known as SARA, the Virginia Breast Cancer Foundation, and the Virginia Counselors Association. The wide range of consumer and patient populations associated with my clients preclude my offering individual comments at this time, but we will be submitting further comments in writing. We are pleased with the extension of the arts program, as has been mentioned by other individuals. We're also pleased that the 1115 waiver application includes supportive housing and employment supports for high-need Medicaid enrollees. However, we're very concerned with the proposed work requirements and the administrative burden that documenting the requirements will cause to enrollees and the cost to the Commonwealth. As the Kaiser Family Foundation recently stated, most adults with Medicaid already work, and most of the non-working face either health or physical limitations to doing the jobs available or have other reasons for not working. People already working or exempt from new work requirement policies may not be the target of new policies, but they will still be subject to verifying work status or navigating an exemption process that could result in eligible individuals losing coverage at high administrative expense for the states. By our own account, your own account, approximately 26,000 or 27,000 Virginians will lose coverage. This is unacceptable. Thank you again for providing this opportunity, and we will submit written comments later. I also have copies of my presentation today.
Thank you very much, Rebecca. We appreciate it. Up next is Ashley Kenneth from the National MS Society.
Good morning. Again, I'm Ashley Kenneth with the National MS Society. The Society does intend to submit written and comprehensive comments at a later time, but I appreciate the opportunity to address you this morning. We do have some sincere concerns about the waiver application as it's been submitted or written, most notably the potential for tens of thousands of Virginians to lose health insurance coverage as a result of some of the harmful proposed provisions, such as work requirements and premiums. The purpose of the Medicaid program is to provide needed health coverage and access to eligible low-income individuals. If Virginians are losing coverage as a result of not meeting work, premium, or other requirements, then the proposed Virginia Compass program does not align with the intended goal of Medicaid. For people with MS, access to needed healthcare services and early and consistent control of disease activity plays a key role in preventing accumulation of disability, and it allows people with MS to remain active in their communities. Furthermore, some people who live with MS or are not yet adequately diagnosed may not meet the requirements needed to be determined disabled or medically frail. The National MS Society therefore opposes work requirements that penalize people with MS who are unable to work due to their disease or fail to meet burdensome administrative requirements. Additionally, the National MS Society believes that premiums, particularly for those below the poverty line, are a barrier to access to healthcare access. Even small premium amounts may be substantial for a low-income person or family, potentially making coverage unaffordable for those who need it most. We look forward to submitting more comprehensive comments and ask you to remain committed to allowing those who live with chronic illnesses to receive the consistent care that they need to live their best lives. Thank you.
Thank you, Ashley. All right, and next we have Beth O'Connor from the Virginia Rural Health Association.
Good morning. The Virginia Rural Health Association advocated for Medicaid expansion because we wanted better access to health care and a decreased burden for rural hospitals and clinics who are required to treat persons who do not have insurance. What I see in this program is a list of bureaucratic loopholes designed to exclude as many people as possible. I am especially concerned about the work requirements. Rural communities typically have a much higher unemployment rate. The proposal has exemptions for areas with high unemployment, but I'm not convinced that the exemptions can be implemented in a practical manner. Administration of the work requirements are likely to cost Virginia's taxpayers more than the program is intended to save. If Virginia needs a workforce program, create a workforce program. If Virginia needs a housing program, create a housing program. But the stipulations I see in this program will result in increasing burdens for rural residents and rural hospitals and clinics, not increasing health and well-being. Thank you.
Thank you, Beth. And that concludes all of the folks who registered for public comment at the beginning of our meeting today. Again, just want to reiterate that we have multiple ways to submit public comment, and we do have 3 additional public hearings coming up over the next couple weeks. So Dr. Ruban, I'll turn it back over to you.
Okay, thank you very much. And we do look forward to hearing from all constituencies. It's really, really important, and your voices will be heard. So I wondered if there is any new business or old business that board members would like to address this morning, or further comments about the waiver application. If not, Dr. Ali, do you know? Okay. If not, then if we could have a motion for dismissal. Is there a second? Okay. Any further discussion? Last chance? Okay, we will adjourn then. Thank you so much. Thank you, Dr. Lee. Thank you, Dr. Motz. Okay.